Good afternoon. Now, because of the technical issue, we could not continue our class in the morning. So now we'll once again restart. We'll quickly complete the session on EEG. So EEG, as the name goes, it is the electroencephalogram. It's a recording and analysis of electrical activity of the brain. We place surface electrodes over the skull, and they are amplified and recorded on a recording device. So only the cortical neurons contribute for the EEG, and it is only 10% of voltage is being recorded because of very high resistance offered by the skull. So it is the Hans Berger, German psychiatrist, who did the first recording of EEG. So, and it was clinically used by Dennis Williams. He is the Hans Berger. So they are called Berger waves. And this is how we place the electrodes. And these are all for the reference that about which you will see a bit later, which are wherever it is placed in earlobe, etc. These are all for the reference, other than skull. So a set of electrodes are placed over 2 points on the skull, and what are the potential difference between these 2 points? This is fed to the amplifier, where those small potentials are amplified many times, which is again conducted to a recording device, where it is recorded over a moving paper by a pen recorder. So we will get these waves. The basis for this is that, you know, the cortical neurons, they have cell body and dendrites. The dendrites are in receipt of multiple inputs from various presynaptic neurons, and there is a current sink there, and depending upon the polarity in the dendrites as well as cell body, suppose the cell body is negatively charged compared to the dendrites, then electrons might move from cell body to dendrites, or it may be vice versa. There is a dipole, or there is a cyclical dipole, which whereby current may move from cell body to dendrite or dendrite to cell body. These things are recorded as waves, and they constitute the EEG waves. Now, to record these waves, we need to place the electrodes, that are piezoelectrodes, and which are usually gold-plated ones. There are about 21 in total, and there are many methods by which electrodes can be placed. The standard one is the standard 1020 international electrode placement system, wherein this point, as I told you, is the nasion, and the back you have enion, the junction between the neck and the skull. So the distance between these 2 points is measured as 100%, of which from an nasion, after 10% of the distance, again you place the FB1, especially in the prefrontal area, the FB1, suppose on the left side, all denoted with 1, 3, 5, etc. And to the right side are 2, 4, 6, etc. And again from there, again 20% distance, you will have F3, and again from there, the 20% distance, you have the C central area or the vertex, and from there again, after 20% distance, you will have the parietal or PZ or P3, and again you have O1, that is about 10% from the enion, that's in the occipital lobe. So this is how they are being placed. Again, once again, in the next video, we'll see the exact placement also. So you place electrodes between nasion to enion using 1020 formula. And again, between 2 pre-auricular area also you place the electrodes. Similarly, along the circumference of the head also you place the electrodes, keeping the 10% formula. So again, along the sagittal plane here also, in this area also, you place the electrodes. This is how you place the electrodes, and you record. Now here there are 2 types of recording. One is the bipolar recording, or they are called montage. Another is the reference montage. Whenever there is a bipolar montage or bipolar lead system, wherein 2 neighboring electrodes, suppose in this case I am just take example T3 and C3, just like this, in the central area, vertex area. Suppose here, this is temporal, this is the central, and like this, suppose what is recorded is the potential difference between these 2 points. So next time it will be between C3 and C2, next time it will be C2 and C4, next time it will be C4, T4 like this in a particular line, or it may be from FP2 to FP4 and from there to C4 or P4 and OZ like this. In any particular plane or any particular line or chain between 2 electrodes, the potential difference is calculated. That is called bipolar montage or bipolar system. So as the name indicates, between FP1 and 2, they are the prefrontal area, and F3 and 4 are the frontal area, C3, C4 the central area, and P3, P4 the parietal, and O1 and O2, these are all the occipital. And these are like this, these are all the placements where they are being placed, and each area represents denoted by this by various denoted like this is prefrontal, and like this every area you place the corresponding electrode. So again you can see from Nasion to Enian how the electrodes are being placed. From Nasion up 10% distance you place the FB1, from there 20% FZ, from there 20% distance CZ, from there 20% PZ, from there 20% O1, and again this is the Enian. This is how along the sagittal area between Nasion to Enian you place these things. And again from auricular area from A1, this is T3, C3, CZ, again that side C4 and T4 and A2 on the other side, on the right side, like this you can put. Again along the circumference you can put this from here 10% area from 20, 20, 20, 20, 10 like this. So FB1, F7 and T3, T5, O1 like this you put. On the other side, suppose FB2 and F6, T4 and T6 and O2 like this. On the other right hand side like this, you have to put the electrodes. And again here also you can see from here between these two, this area, this circumference you can say. Here also FB1, F3, C3, P3 and O1. This is a circle. Again here also you put 20% distance. This is called 20% system. This 20, 40, 60, 80 like this. So here it is about 25%. So this rule you have to follow accordingly. And various areas of the skull you place the suitable electrodes. They are denoted with the numbers. You can see. This is the overall picture how they are being placed. So as I said, the referral montage, when the single reference point is used in all electrodes, and there's one active electrode and the other electrode is from central point or from a point which is outside the scalp, maybe from earlobe or maybe from chin, etc. In bipolar, we use several reference points. That is, 2 neighboring points are taken, and in the particular line or chain, they are being recorded. In bipolar montage, the electrodes form a chain and pass side by side from front to back. That's how it is being recorded. Like this. From here to here, here like this. And from on a chain, they will record. So about 21 electrodes, sensitivity is 5 to 10 microvolts, and vapor speed about 3 centimeters per second, and length 2 minutes for each montage. It can be, activation can be done by maybe photic stimulus or maybe by hyperventilation. You can do it. These are normal EEG, so a wave pattern. So these are the reference montages. So it's all recorded with eyes closed. So you can see the FB2, FB4 like this. And in each of these are all on the right side. You have, and these are the left side like this. Right side montage and left side montage. You can see the recordings. Of course, for your level to a recording of EEG or maybe interpreting is not so much necessary. The only thing you should know how it is done. That's all. That much is sufficient for you at undergraduate level. For doing an ECG, it is not the question normally. It is not asked or it is not required at this level. Only when you get into neurology or maybe psychiatry, wherein you may be required to place the electrodes and record and interpret things like this. You should know some basics. What is EEG, how it is done, and what are the waves, and what is the utility of the EEG. That much if you know, that is more than sufficient at this stage. So the normal alpha waves, they're having frequency between 8 to 13 hertz, and they're highly rhythmic, and it is found in normal eye with eye closed. Whenever the eye is closed, then it will be the normal alpha wave. As soon as you become concentrating, or when you just open your eyes, the normal regular alpha rhythm will be blocked. It's called desynchronization, and irregular wave pattern will be seen. That is called as alpha block. It is called normal alpha block is an example of synchronization, and alpha block is an example of, or it is otherwise called as desynchronization, because a normal regular wave pattern is disrupted. That's called alpha block. So it is highly rhythmic, and it is prominent in posterior cortex, and it's mainly in occipital, temporal, and parietal cortex. In these areas, normally you will find recording of alpha waves. And normal beta wave having frequency, high frequency, more than 13 hertz, and frequently it is normal with eyes open, and it is found in the frontal and central regions. And they normally have low voltage. Whenever the frequency is more, the voltage becomes less. That is the thing. So these are all the beta waves of different leads. These are here they have taken between two leads. Bipolar recording system. So again, this is the alpha effect of eye closure. You can see the normal alpha pattern is recorded. Whenever this, where here eye is open, here this eye is closed. The theta waves, here the frequency about 4 to 7, and it is found in the frontal and temporal regions, and it is more prominently recorded during drowsy and sleep. You can find these kind of tracings, and they are nothing but small amount of sporadic isolated activity found in normal awake state also. These are all the theta waves. And delta frequency is less than 4 hertz, so it is more prominently recorded during deeper stage of sleep, and it normally not present in the normal awake EEG. You won't find theta waves in the normal awake EEG. So whenever you are awake, this is how the EEG pattern will be. This is during light sleep, and whenever you have REM sleep, you will have, you can say, sleep spindle as well as K complex, etc. All those things will be recorded here. And whenever during deep sleep, the wave frequency will be very low, and very high voltage wave will be recorded. Whenever there is a brain death, there won't be any electrical activity. So EEG is mandatory to be taken before declaring somebody as brain death, before any harvesting any organs, especially nowadays there is something called Jivan Dan. So they may recover or harvest the organ in a brain dead individual, for which medical legally it is mandatory to do EEG. So I'll show some videos.
Patient blinks their eye. The eyeball moves upward into the head.
So we'll see from the beginning.
In this video, we will review the basics of the electroencephalography, how it's recorded, and how these results can be used in knowledge. We will review several topics briefly in this video. The topics will be reviewed in further detail in subsequent videos for those interested in deeper dives into core EEG. We'll review some of the basic terminology of EEG, how EEG is recorded, how EEG is displayed for interpretation, some common And then parasagittal measurements are made, separated by 25% of the limb. And finally, transverse measurements are made. The intersections of these two lines is where the final electrodes are placed. Once all of these marks have been placed, the electrodes can be applied to the scalp of the patient. The electrodes are labeled as is shown here. The system is very simple, and each electrode is represented by letters and the numbers indicate the side of the head, so that odd numbers are on the left side and even numbers are on the right. In general, lower numbers mean that the electrode is closer to the midline. So you can see here that C4 is closer to the midline than E8. And the midline itself is represented by a Z, which stands for 0. The letters are indicators of the position on the head. In this central chain of electrodes, you can see that the F stands for frontal, the C for central, and the P for parental. EEG is recorded using the technology of the differential amplifier. The differential amplifier takes two electrical inputs and displays the output as the difference between the two inputs. This is particularly useful at recording and displaying very small electrical signals, such as those in EEG. For example, you can see these two waveforms, which are very similar, except for one small difference demonstrated here in red. When these two signals are placed in the differential amplifier, you can see that the output is simply
escape చేస్తామా
ముందు పెట్టలే మధ్యలో వస్తుంది వీడియో
అవునవును
ఓల్డ్ డెలివరీ మీకు ఇందా ట్రైల్ చేయండి కదా ఎలా పెట్టాము
వచ్చింది అదే రన్ అవుతుంది వాళ్ళకి వెళ్ళట్లేదా
ఫోన్ చేయండి దాని వీడియో రావట్లేదు సార్ ఇప్పుడు సార్ది వీడియో పిల్లలకి కనబడట్లేదు అటు సార్ జయబాల సార్ మరి ప్రెజెంటేషన్ అయిపోయింది వీడియో మాత్రం కనబడలేదు మళ్ళీ ఫోన్ చేశారు అంటే క్లోజ్ చేసిమంటారా ఆఫ్ చేశాను మళ్ళీ ఏం చేయాలి స్క్రీన్ లో ఉన్నదా సార్ గిరి గారు సార్ అటు నుంచి ఆల్రెడీ ఇందాక అలాగే చెప్పారు సార్ ఇందాకలా సార్లు అయినప్పుడు వరుసగా 5-6 లక్షల సార్లు ప్రైవేట్ నుండి వీడియో రావాలి మనం తీసేసి మళ్ళీ పెట్టాలంటే ఇది ప్రొడక్షన్ ఉన్నారు ఈ నాకైనా అప్పుడు వస్తాను వాళ్ళు తిరిగారు ఇప్పుడేమో ఇప్పుడు మీరు ఏది మళ్ళీ ఆన్ చేసి ఆఫ్ ఆఫ్ చేశారు నన్ను మళ్ళీ ఏం చేయమంటే చెప్పండి చేస్తాను సార్ రూపాయలు కమ్ముతుంది సార్ వీడియో అదే సార్ ఆయన మామూలుగా వస్తారు కదా షేర్ స్క్రీన్లోకి వెళ్ళాలా సార్ ఓకే సార్ ఓకే సార్ ఇదే కదా సార్ సార్ షేర్ అన్నా సార్ అదే వస్తుందా అదే ఇది
అయిపోయింది.
సార్ వస్తుంది.
స్టాప్ సైడ్ వెళ్ళిపోయి అక్కడ మీడియం వెళ్ళాలి.
మరి అదే నన్ను అడుగుతున్నాను.
స్టాప్ సైడ్ వెళ్ళిపోయి
రెండు ఒకటే కదా సార్?
ఇది అయిపోయింది.
రెండు ఒకటే సార్. పవర్ పాయింట్ స్లైడ్ షో అన్నారు.
అదే వీడియో చూపించారు.
వీడియో ఎక్కడ సార్?
దీని కింద పెట్టారు
ఇందులో
కదా, మీ కింద మనం రికార్డ్ చేసి పెట్టారు
సార్. డెస్క్టాప్ మీద ఉందంట.
In this video, we will review the basics of the electroencephalogram, or EEG, how it's recorded, and how the results can be used in clinical neurology. We will review several topics briefly during this video. The topics will be reviewed in further detail in subsequent videos for those interested in deeper dives into the world of EEG. We will review some of the basic terminology of EEG, how EEG is recorded, how
recording అవుతుంది. ఎన్ని డేస్ ఒక నిమిషం. సార్ 716 సార్ 716 5 4 సార్ 663 663 663 సార్. 663 సార్. సార్ ఇంకేదో వచ్చింది. యూ వాంట్ అలౌ ద యాప్ టు చేంజెస్ విత్ డివైస్. సార్ do you want to allow this app to make changes to your device? మళ్ళీ వచ్చి డిస్కనెక్ట్ అయింది. అవునండి. అందులో ఎట్లా మాట్లాడుతున్నాం సార్? ఏం
ఇంట్రొడక్షన్ EEG పెట్టాం
సార్. ఇంట్రొడక్షన్ EEG సార్. లాస్ట్ వన్ సార్. లాస్ట్ వన్.
electroencephalogram, or EEG, how it's recorded, and how the results can be used in clinical neurology. We will review several topics briefly during this video. The topics will be reviewed in further detail in subsequent videos for those interested in deeper dives into the world of EEG. We will review some of the basic terminology of EEG, how EEG is recorded, how EEG is displayed for interpretation, some common EEG patterns, and how we can use the results of EEG for making decisions in clinical neurology. First, we will start with the terminology. The system by which EEG electrodes are applied to the head and then displayed on EEG recordings is called the International 1020 system. The International 1020 system is a standard method of measuring the head and placing electrodes. It depends on 4 main positions on the head that are easily transferable between patients. First is the nasion at the bridge of the nose, then the inion, the bony prominence at the back of the head, and then 2 preauricular points just anterior to each ear. Consider this diagram of a head looking from the top down. The first measurement that is made is from the nasion to the inion, front to back. This measurement is then divided into 10 and 20% increments and this is how the 1020 system gets its name. Marks are placed, and then a measurement is made from one preauricular point to the other. Again, this is divided into 10 and 20% increments, and additional marks are made. Further marks are made around the circumference of the head, and separated by 10% increments. And then parasagittal measurements are made, separated by 25% increments. And finally, transverse measurements are made. The intersections of these two lines is where the final electrodes are placed. Once all of these marks have been placed, the electrodes can be applied to the scalp of the patient. The electrodes are labeled as is shown here. The system is very simple, and each electrode is represented by letters and a number. The numbers indicate the side of the head, so that odd numbers are on the left side and even numbers are on the right. In general, lower numbers mean that the electrode is closer to the midline, so you can see here that C4 is closer to the midline than T8. And the midline itself is represented by a Z, which stands for 0. The letters are indicators of the position on the head. In this central chain of electrodes, you can see that the F stands for frontal, the C for central, and the P for parietal. EEG is recorded using the technology of the differential amplifier. The differential amplifier takes two electrical inputs and displays the output as the difference between the two inputs. This is particularly useful at recording and displaying very small electrical signals, such as those in EEG. For example, you can see these two waveforms, which are very similar, except for one small difference demonstrated here in red. When these two signals are placed through a differential amplifier, you can see that the output is simply the difference between them, and all of the other commonalities are cancelled out. Another way to think about this is to think about the very common children's game that is seen on restaurant menus. You can see that the picture on the left and the picture on the right are very similar, except for a few small differences indicated here. If we were to consider the picture on the left as input 1 and the picture on the right as input 2, we could put these two quote-unquote signals through a differential amplifier, and the output would look like this. This example is a good way of thinking about EEG signals as something that is not absolute, but rather the difference between two inputs. EEG can be displayed in different ways, which are all known as montages. The most common type of montage is a bipolar montage. Here I have a picture of the head from the top down. If we display the difference between FP2 and F8 as a single tracing, it would look something like this, and we call this single tracing a channel or derivation. Next, we move posteriorly and look at the difference between F8 and T8 and display this as a different channel. We continue to move posteriorly, and we have a string of recordings from the front of the head to the back that are linked together. This string of recordings is called a chain. In this case, this is the right temporal chain. Several chains can be placed together in a single display, such as this example of an anterior-posterior bipolar montage. This anterior-posterior bipolar montage is laid out as if we are looking at the top of the head of the patient and they are facing to the right. Therefore, we first see the left temporal chain, then the left parasagittal chain, then the midline, then the right parasagittal chain, and then the right temporal chain. At the bottom, we see a single EKG channel as well. Another common type of montage is called a common average reference montage. Here, in a single channel, rather than looking at the difference between two adjacent electrodes, as in a bipolar montage, we look at the difference between an electrode of interest and an average of the signals of the rest of the head. Here we can see the layout of an average reference montage, which is very similar, but again we are comparing each channel to an average of the rest of the head. Some relative strengths and weaknesses of different montages are reviewed in a separate video. I will briefly review some commonly encountered EEG patterns, simply to whet your appetite for further EEG learning. One of the most commonly encountered entities on an EEG recording is an eye blink, and so I will review this briefly. We have to think about the eye as a dipole with a polarity. There is the retina and the cornea. The retina is negatively charged, and the cornea is positively charged. If we think about something as simple as an eye blink, In this crude diagram, when the patient blinks their eye, the eyeball moves upward into the head, a phenomenon known as a Bell's phenomenon. This is the normal response during eye blinking. If we think about this from the perspective of the EEG electrodes closest to the eye, we can see that this upward deflection of the eye will cause a large positive signal at the frontal polar electrodes FP1 and FP2. On EEG, this results in a very large deflection in the frontal polar electrodes on both sides, indicated here. The alpha rhythm is the most commonly encountered rhythm during wakefulness. Here I have highlighted the alpha rhythm. The alpha rhythm is a normal rhythm during wakefulness and is especially prominent when the eyes are closed. Although there is a range of frequencies for the alpha rhythm, it is usually around 10 Hz or so, which is the case in this patient. Focal epileptiform discharges are generated by synchronous abnormal electrical activity in a large population of neurons in the cortex. Focal epileptiform discharges can be an indicator that the brain is capable of generating seizures and can be a helpful prognostic and diagnostic finding in patients with epilepsy. Here I have a normal awake EEG and an anterior-posterior bipolar montage. Without going into too many details, there is a focal epileptiform discharge here. You can see that this is in the left temporal chain. I will go into how to sort out the polarity of this epileptiform discharge in a separate video, but here I've indicated the areas of maximum abnormality for this particular epileptiform discharge. Here is a slightly different focal epileptiform discharge. Whereas the other discharge was maximal in the temporal region, this discharge is maximal in the posterior aspect of the head, on the right side, and I have shown its maximal field in this diagram. Generalized epileptiform discharges are seen in patients with generalized epilepsy syndromes. Here is an example of a run of generalized epileptiform discharges. You can see that these discharges involve basically the whole head all at once. There is a long run of these discharges lasting almost the entire length of this page. These are actually the typical 3 Hz generalized spike and wave discharges seen in childhood absence epilepsy. It is useful to think about the diagnostic yield of EEG. In studies of patients with epilepsy, the likelihood of finding an epileptiform discharge, either focal or generalized, in a single EEG within 24 hours of a first seizure is about 50%. If the EEG is done more than 24 hours after the first seizure, the likelihood might drop somewhat. This means that half or even more than half of patients with epilepsy might have a normal routine EEG. On prolonged 24-hour EEG recording, the likelihood of picking up some epileptiform discharges is much higher, in the range of 80 to 90%. But again, this means that 10 to 20% of the time, even prolonged EEG can be normal in a patient with epilepsy. Several routine 30 to 60-minute EEG recordings can produce the same yield as a 24-hour recording, but may be less practical. To think about why some patients with epilepsy might not have epileptiform discharges, we can consider a couple of things. Here I have shown a coronal section of a brain. I have placed the approximate position of the standard EEG electrodes on this image. The two major determinants of seeing a scalp abnormality are the area of cortex involved and the location. For example, I have shown here a star which represents a small area of cortex that has synchronous abnormal electrical activity. Because this area is small, it might not be picked up by the overlying electrodes. If a larger area is involved, such as shown here, it might be more likely that this abnormality would be picked up by scalp electrodes. In general, 10 to 20 square centimeters of cortex has to be involved in order for the abnormality to be consistently demonstrated on scalp EEG. The other main determinant of a scalp abnormality on EEG is the location of the synchronous cortical activity. In this example, I have shown a very superficial area of cortex involved, which might be more likely to be picked up by scalp EEG electrodes. If a deeper area of cortex was involved, such as in the cingulate gyrus, shown here, in the mesial temporal structure, shown here, or in the insular cortex, shown here, it may be less likely that such abnormalities would be picked up by the more distant scalp electrodes. In this video, we have reviewed basic EEG terminology, how EEG data is recorded and displayed, some common EEG patterns, and how EEG may be used in clinical neurology. Obviously, this is a very superficial review of EEG, and for further details, feel free to peruse some of the other videos which explore EEG in further depth.
చెప్పాడు నాకు ఇంకోటి yes sir
Preparation, EEG test preparation.
Hello, my name is Barbara Walsh, and I am the supervisor of the outpatient EEG lab at the Cleveland Clinic, which is located at the main campus in Cleveland, Ohio. If your physician requests that you or your family member have an EEG, I want to prepare you for the procedure, answer questions, and allay any fears you may have. EEG is an abbreviation for electroencephalogram, which is a recording of the electrical activity generated by the neurons of the brain. We do EEG testing for various reasons, which include epilepsy, syncope or passing out spells, and mental status changes. Oftentimes, teachers will describe staring spells in school, and the pediatrician will order an EEG to determine if these are brief seizures. If you are consulting with a doctor here at the clinic, we make every attempt to schedule the EEG prior to the consult so that your test may be looked at before. The test will be officially read by the end of the day that the test is performed. If you are sent by a physician outside of the Cleveland Clinic Health System, the report will be mailed to this referring doctor. If your doctor requests the results sooner, he can call. I will be happy to fax you the results. I want to familiarize you with the desk you will be checking in at, which is S51, as well as the team of EEG technologists that will be performing your exam. This group of technologists has the expertise and techniques to perform EEGs on all age groups and difficult cases as well. They are very child-friendly and make every attempt to communicate to the patients exactly what they are doing. Since all patients will not be able to understand what is happening, you may hear crying or signs of discomfort when passing through our hall, but please understand that the test does not hurt at all. I will go through instructions you must take in preparation for the test, then the steps we take in the actual performance of the EEG. Your hair should be clean and free of hair oil, tonic, and spray, as well as hair weave. Do not stop taking any prescribed medications unless specifically told to do so by your physician. We make every attempt to obtain a natural sleep recording, so do not consume any caffeine-containing beverages the morning of the test, and these include coffee, tea, cola, and chocolate drinks. The night prior, try to sleep 2 to 3 hours less than usual unless sleep deprivation has triggered a major or severe seizure in the past. If you are able to be sleep deprived, please bring a driver along for your safe arrival and trip back home. If you have a DBS, please bring your magnet. In an effort to stay on schedule, if you are late for your appointment, we may need to reschedule. We encourage parents to bring any small, special stuffed animal, blanket, or music recorder that may serve as comfort to your child. The technologists will have you lying down on a hospital bed that raises so that they can easily work on the head. A rolled pillow will be placed under the head to raise the head slightly so they can view the head from all angles. They will then begin to measure the head with a regular cloth tape measure and make marks on the head with a wax pencil. These marks are very specific to each individual's head size and are the places that the electrodes will be applied. This system is used internationally and is called the 1020 system of electrode placement. The test is run on a computer that looks like the ones you have in your own homes and schools. We will be applying 25 electrodes and 2 EKG stickers to the chest to measure your heartbeat as well. The electrodes are 48 inches long and multicolored with a disc or cup on the end that is attached to the scalp by an adhesive method. This small disc is made of pure silver with gold plating over it. These electrodes are plugged into a jack box that has a cable attached to the computer. In looking at EEG patterns, we compare the left side of the brain to the right side, so these electrodes must be placed very precisely. The application can take between 30 and 40 minutes. Your doctor may order a routine EEG or a multi-hour or longer EEG. For the routine EEG, you will be allotted 90 minutes for the appointment, and this will include the electrode application process, the actual running of the test, which is 20 to 25 minutes, along with the cleanup process. For the multi-hour test, you will be allotted 3 hours, and the only difference is that the EEG will run for 75 minutes. Sleep is especially important in this recording since we have an extended time to record the data. I want to familiarize you also with 2 electrode application techniques that we may be using. The first is the paste method. The technologist will first rub a small amount of skin preparation gel on the measured spot using a Q-tip. Next, we will fill the cup up of the electrode with a paste substance that has the consistency of toothpaste, and then adhere it to the scalp with a cotton ball. This method can only be used on patients that are able to hold still and only for the shorter exam. The electrodes are more easily displaced with this method if head movement occurs. I want to show you some photos of this measuring and application process as we do it in our lab. You will see it is harmless and our patients are relaxed and even smiling. The second method of application is used when, due to patient's age or medical condition, is unable to keep the head still, or in cases when the test is run longer and the patient may need to turn from side to side to become comfortable to sleep. The tech will once again prepare the scalp with the Q-tip and skin preparation, and then will glue the cup of the electrode to the scalp using a piece of gauze dipped in a chemical called collodion. Collodion has a strong smell of ether and makes the surface stick very tightly when air is applied and the glue is dried. The air we use is simply room air with tubing attached and a stylet on the end. It is comparable to a hair dryer, but with cool air coming out. Next, we must squirt a small amount of pink conducting cream into the small opening in the top of each electrode disc to help in the flow of the electrical activity of the brain. This may seem a bit scary to some since we must use a syringe to squirt in the lotion, but the syringe is for squirting purposes only. We use a blunt-tipped needle attached to the end of the syringe, but once again, the needle is blunt with no sharpness to it. It has to be used because the hole is very small. After all this preparation, we are now ready to run the EEG. The room will be made dark, quiet, and the door closed to promote relaxation. The tech will tell you everything that will happen before it is performed. There are 3 activation techniques that we try to do on all patients. These procedures are done to attempt to bring on a typical seizure or event that brings you in for diagnosis. In certain patient populations that are predisposed, photic stimulation and hyperventilation may actually bring on the typical seizure. During photic stimulation, the tech places a lamp over the eyes and asks that you keep your eyes closed. A light will begin to flash, starting at faster rates of speed and slowing down progressively. At the end, we'll have you open and close your eyes and end up with one faster frequency. Despite the eyes being closed, you will be able to see the flashes and perhaps different colors or patterns through your eyelids. If we do obtain a positive response in the form of a jerk or twitch, the light will be turned off immediately. Another activation procedure we use is hyperventilation, or a deep breathing exercise. If you have any history of heart or breathing difficulties, we may omit this portion. We simply ask you to take faster and deeper breaths for 3 to 5 minutes, blowing in and out through your mouth. You may experience dizziness or lightheadedness, but this is a normal response and will diminish a couple of minutes after completion. For smaller children, this exercise is also important, but we may ask the child to blow on a pinwheel or blow bubbles, since this actually gives us the same results. Once again, certain patient populations may actually have a seizure or produce brainwave abnormalities with this activation, and we will discontinue if this occurs. Now we are ready to exercise the third type of activation, which is natural sleep. I call sleep an activation because an EEG may show totally normal brain waves until sleep is obtained, and the abnormality may manifest itself. The technician will alert you at the end of the allotted time and ask several questions to make sure you are awake and alert. This is what we call mental activation. Our brain waves look different when we are awake, asleep, and drowsy. We need to prove to the physician analyzing the test that our patient is fully awake. For help in the analysis process, our EEG machines are equipped with digital video recording so that the doctors can correlate brain activity with the patient's clinical manifestations. Now we can begin with the lead removal and cleanup process. We make every effort to remove all remnants of any of the adhesives used from the hair and scalp. If we use the paste and cotton ball method, the cleanup is rather easy. This paste is water soluble, and we wash it out with a cloth using warm water and combing through the hair. Shampooing will further remove it once you are at home. If we had to use the collodion method, we will need to use acetone for the removal. Women may recognize the smell of acetone since it is present in fingernail polish remover. This odor is also quite strong. For the babies and smaller children, we also have a non-acetone remover, which requires a little more scrubbing and has an oily base to it. I hope I have covered the important steps in the process as clearly as possible. Please feel free to ask your EEG technologist any questions that may arise during the actual exam. Everyone in the Epilepsy Center welcomes you, and we will be happy in making your testing process here as smooth as possible.
So here, today we have seen two videos about some basics, how it is being done and what are the preparations, how it is being stimulated by hyperventilation or photo stimulation, etc. Now at the end, you should know the application of EEG. Number one, by recording EEG, we can record a local maybe hematoma or edema in a particular area where EEG waves will be diminished, or will become low voltage, or it may show some spikes at particular area, showing some epilepsy or epileptic foci, or sometimes it can also show certain brain lesions or tumor, etc., where abnormal delta waves can be seen whenever there is organic lesion in the brain. Or as I said, in the case of brain death, it doesn't show any spikes or any waves. Simply, that will be very plain line, so by which we can identify somebody is alive or brain dead. So it has got multiple applications. Mainly, it is used for epilepsy as well as certain other brain lesions. Sometimes it is used. Sometimes it can be localized edema, hematoma also can be identified by a diminished EEG pattern. These are some of the utilities of doing ECG. Now, for your level, as I said, if you know what is EEG, what are the waves, how it is being recorded, what are the basic utilities of these things. For this level, it's okay. Once you go to psychiatry or neurology, you will learn detail about these things, the techniques, how you place the 1020 system, and recording how the various waves are being recorded and interpreted. Those things you can see, learn a bit later. So with this, we'll call it a day and have a nice day.